I'd like to take you back a couple of years when Dr. Bibb Allen was such a great leader for our commission. Talk to you about the concept of the escape fire. The story in brief was of firefighters fighting a bushfire who realized that the fire was outrunning them. There was no way they were going to escape it. One of the firefighters decided to pursue a completely counterintuitive solution. He set a fire around himself so that the oncoming fire would have nothing to burn. He lived. The tragedy was that he was not able to persuade his fellow firefighters to join him. So we are talking about counterintuitive solutions. We also talked to you about the business principles outlined in Spencer Johnson's seminal book, Who Moved My Cheese, and you saw a slide from Bob Zeman. It talks about how hard change really is and how instinctively we will really fight to stay with what we have rather than pursuing new strategies. And last year we talked a little bit about the movie The Artist, which is where a silent film star realizes that he has to find a skill in himself that he maybe never knew he had. He has to learn to dance to survive in the new world. So you've heard a lot about Imaging 3.0 over the last couple of days. What is it and why do we think that it is going to be radiology's escape fire? So I'll take you back to the graph that I showed you earlier this morning. And if you think about where we are now, where our amazing technology has driven huge advances in productivity for us, that's what we're calling Imaging 2.0. And Imaging 3.0 is where we want to be, where our success will be driven and defined by our value in the care continuum. Imaging 3.0 is our roadmap for that transition. You heard from Keith. We are more productive than we have ever been, but our presence and our perceived relevance in the healthcare system is not what we need it to be. The three aims, the triple aim of healthcare, as defined here as improving population health, improving the experience of care, and reducing the per capita cost, those aims are being baked into reimbursement and healthcare policy at every level. Far from being part of the perceived problem, we know we're not part of the problem. We know that we deliver high-value care, but through misinformation and some misaligned incentives, we have certainly been perceived as part of the problem. Imaging 3.0 is how we demonstrate that imaging is a high-value solution and that we are the providers that deliver that. It's a practice model. It's a toolkit for making that transition to value. It's an advocacy tool. It's a story that we can tell ourselves, that we can tell our local communities, and that we can tell national policymakers about how we deliver value and thus get incentives aligned. It is a basis for us to empower our patients in their imaging care. It applies to everybody in the care continuum. It uses a lot of IT, as you've heard from Keith. It also redefines what it means to be productive and valuable. It's very importantly about establishing relationships. And it fits into large systems, it makes us relevant, it fits into small practice systems. Our patients are very central. Imaging 2.0 focused on the interpretation. We do that incredibly well. That's good, but it's no longer good enough. Imaging 3.0 moves us beyond the interpretation. It takes us through the process of considering imaging in the care decision to make sure that appropriate imaging is ordered. It makes sure that the reporting that we deliver is meaningful to our colleagues, to our patients, that it's actionable. It puts patients first, and it gives us a story and a toolkit to prove it, for making sure that our patients' experiences are absolutely enhanced and maximized by demonstrating to our colleagues and our patients that we care about quality and safety, and by empowering our patients. It uses a variety of tools that are available now to make sure that we can impact our patients and our referring physicians to deliver the highest value of care. All of these tools, all of these strategies come under the Imaging 3.0 umbrella. Now, I know that there are a lot of you who are asking, especially around tools like decision support, are all of these Imaging 3.0 tools going to make me more relevant, or are they actually going to make me obsolete? Well, history is littered with wonderful companies and wonderful products that have become obsolete. But sometimes the outcome is better. And we know that change is hard, and that's what we are trying to do as leaders of the profession and as colleagues of all of you, is to help ourselves move forward. So the question that you have to ask us is, well, So we'll acknowledge that change is hard. What's the ACR doing to help me manage this change? So I think you've all gotten this brochure in your packet. If not, it's easily available on our website. And I'd ask you to take yourself on the journey that we outline in this leaflet, because you'll see how many things that you can do in your practice right now to move towards Imaging 3.0. But at the national level, what the ACR is doing is focusing on aligning incentives to make sure that the payment models actually reflect your value in the care continuum. Because let's be frank, currently there are no incentives to reduce volume. There is no reward for managing imaging utilization and assuring that it's the right exam on the right patient to get the best diagnosis. So we're working hard, as you've heard at our session yesterday, to try and get the use of decision support into payment policy. Now, we also know that this is not going to be something that every practice can adopt right now, that every system can adopt right now. And that's why we continue to fight so hard for the fee-for-service reimbursement, the world in which we're all working, to make sure that we're doing as well as possible, as you've heard, in the face of quite significant obstacles. We know that there are skeptics, and we've thought a lot about this. The good news about this strategy is that it builds on the 5 pillars of the ACR. These are the principles that we all work on already. And when we think about what success means with Imaging 3.0, I think it's really hard to argue with wanting our patients to have convenient access without payer-imposed steerage, the highest quality imaging, to understand what their imaging test means and understand what it means to their diagnosis, for our referring physicians to have transparency and understand how they can best use imaging with our consultation and support, to have evidence-based guidelines. You heard, I thought Dr. James was so impressive talking about how our reports actually have to be relevant. We can't expect our physicians to know more about imaging than we do. And most importantly for us, who can argue with us being integrated fully into the patient care continuum, where we have confidence in the recommendations that we're making? It has to lead to increased professional satisfaction, so that those of us who answered that yes, we would choose radiology again, will continue to be able to practice the specialty we love in a relevant way that assures the survival of our specialty. So in summary, Imaging 3.0 is about maximizing radiologist value and our collaboration with other physicians. It is about empowering our patients. Most importantly, it's a story that we can tell about the value that we know we bring to the care continuum. I hope you'll take it to Capitol Hill tomorrow and change the discussion about radiology. Thank you. So before the senator comes up, we're going to take one more question. We will, as I say, we'll possibly have some time for questions now, but our open mic session this afternoon is focused on Imaging 3.0. I hope you will have your ideas. We're looking forward to a very robust discussion, but let's run the question. I can't see the results. That's great to hear.